Well, substance use disorders in and of themselves can be terminal illnesses. So sometimes we see patients who are facing the ends of their lives because of their substance use disorder. But in terms specifically within palliative care, more broadly, it's that it makes, if you're actively in the midst of a substance use disorder, it makes treating whatever your other underlying medical condition is much, much harder. It can get in the way of sort of our usual tasks of life closure and coming together with your family. You know, if you've been really fully living in the depths of a substance use disorder much of your life, you're often estranged and alone. So that can make it harder for our hospice teams to take care of them. And it can set up for more suffering when we're afraid to give patients medications they may need for the tumor that's invading their spine, because we don't want to worsen their heroin addiction. When in fact we may be able to use opioids quite safely in this population.
That we need to individualize care and really weigh the risks and the benefits for people as an individual. And while we may be used to reaching for a standard group of therapies for a particular issue, for any individual, they may or may not be the right balance of benefit and risk. And in this population of folks who have either an active or even historical substance use, especially depending on what that substance is of choice, there are lots of options that are actually out there that we know of today. And sometimes it's better to use the usual weighing of benefits and risks to find the right treatment options for that person.
Substance use disorders are super common in that they can be there in any of our patients, not just the person who looks like the typical person with no teeth who's disheveled, but the mom, the grandma, your department chair who ends up on your unit or on your service. And it's important to do, just as we do for any physical condition, to do an impeccable assessment of their substance history and make sure we're not missing someone who's been misusing alcohol all their lives. And that's going to cause lots of trouble.
So I liken it to, I tend to look at big picture things. So I liken it to all of those conditions that if we're not thinking about, we're going to miss and not diagnose. While, first of all, nobody is at no risk. That does not exist in this world. Even a 92-year-old can have some issues that we don't know about, or they can simply have a genetic predisposition that's never been triggered before. So nobody has no risk. There are also families involved with what we do, and they are part of the medical team, and so we need to remember that. But if we're not thinking about it, I love the word consider. When we're creating our plans, there are things that we need to consider. It doesn't mean we need to act on anything if there's nothing to act on, but we need to consider that this may be an issue and respond accordingly on an individual way.
One thing Amy was mentioning to me before we walked in that I think was really critical is to not be afraid of patients with substance use disorders. I think, yes, they can present with very challenging behaviors, but the patients we see in general are the most challenging ones in the hospital or in the home care setting. And this is just one more thing. And by having a few tools and a good team, you're able to provide good, compassionate, whole person care for those people with substance use disorders.